about the correction of angular deformities with external fixation. So these are my disclosures. So probably most of the people who are here probably will do an internal fixation, supramalenostomy whenever it's needed. But there are some cases that will require, as previously said in the previous talks, will require more complex and probably more severe deformities, will require a special strategy to get corrected. And in this is very important that the state of the art in external fixation has been changed in the last 20 years, where we have been transitioning between the classic ellipsoidal frames, which are very versatile. They have a steep learning curve, and most of the correction is done using hinging rods. And we have traveled to an era where most of us are exposed very frequently with hexapod frames, which it's a multi-planar frame that creates a virtual hinge, has an easier assembly. The corrections are made with a software program, and we can have accurate and precise correction. So these are my level 5 indications, because I was thinking, when will I think about putting an external fixation? And probably these are partial arthritis in the context of a severe complex SMO deformity, which means a multiplanar in the oblique or rotational plane, and multiaxial. Also, history of infection and osteomyelitis, poor skin condition, patients with indication of SMO and distraction arthroplasty, limb length discrepancy, and also distal tibia non-union in the context of ankle arthritis. So what are the advantages? This is a minimally invasive procedure. We do not do any open approaches. We do a low energy osteotomy, a transverse one. We can have accurate deformity correction and residual programming. What this means, if we mess up, we can go back and we can do any residual programs that are needed until we are happy about the correction. We can perform ankle distraction at the same time. We can do early weight bearing. There's no remaining hardware, which is very important, thinking that all these joint sparing procedures will go towards a total ankle replacement or an ankle arthrodesis. So it's very important to have no remaining hardware. And also an axial lengthening through the osteotomy, which is very important because shortening is a deformity in the axial plane, and most times it's not properly seen. So disadvantages, obviously the number of surgeries. It requires at least the frame removal, the discomfort. Usually these patients require, depending on what type of indication they have, they require a prolonged time in the X-fix. And we have a common problem that's HAFPIN and K-ware infection. These are some WhatsApp images with my patients, which they always tell to me where is their infection. We have to go with antibiotics, and it demands better understanding with your patients, and the patients should be well trained in correcting the deformity with their frame. So how do we do it? These are the typical 3 scenarios that we use. We have a single level distal tibia that we call when we are only doing the SMO. It consists of 2 rings attached with 6 struts. When a double level is used when we use SMO and ankle distraction, which means that we have to do a more distal level in order with using rods or using another hexapod level to do the distraction. And we can do more complex deformities with the triple level distal tibia and ankle for SMO, ankle distraction, tibial lengthening, and proximal tibial alignment. And also we can do some foot correction in the meantime. So this is the more classic strategy, which uses it's the simple configuration where we do the minimal invasive transverse osteotomy using a jiggly saw, a bore, mini open, but it's very important to be a low energy osteotomy as we are confining in using the distraction osteogenesis. And this is very important because the quality of the regenerate depends mostly of how we treat the soft tissue. And it's important to see that we can lengthen through the osteotomy. So most of the softwares allow us to do this type of planning of any kind of deformity of the distal tibia, and we can do all of simulations and try to assess how is the best way to correct this. Obviously, more severe deformities should be treated gradually in terms not to produce any tarsal tunnel syndrome or neurovascular complications. And we can program this very specifically. We can do different times for us to do the axial lengthening first and separate the vectors that are involved. And we can have simulations of how this is done and see if we're okay with them. If we're not okay with them, we can stop them and do it again. So this is one case. We have an oblique valgus deformity with recurvatum of the distal tibia. In this case, we put a single level frame. In these cases, we do a transverse osteotomy and transverse osteotomy of the fibula also. This is the patient during the treatment. She can walk. Usually, we try to make them walk at least 2 weeks postoperative. And this is the final result. We have a multiplanar correction with no hardware, minimally invasive, and no open approaches. So when we're talking about double level, it's not the topic of this talk about talking about distraction arthroplasty, but we can do it with another level using hinges in order to do the distraction and also allowing the patient to move the ankle during the procedure. This is a case from my friend Austin Fragment, which I learned a lot from him. This is a patient that has this valgus deformity with initial arthritis. This is the deformity she has. Also, same strategy, an upper level to do the transverse osteotomy of both the fibula and the tibia and the ankle distraction. And this is the final result with some restoration of the width of the tibio-teres joint and a normal length alignment. So this is a case that I want to show you because this is a case that it's not having partial arthritis, but it's a patient that's a 14-year-old that had an ankle fracture when he was 8. He has a severe varus deformity with a shortening of 3.5 centimeters. This is the X-ray, and you can see just at least a 45-degree deformity in the coronal plane. And we use also the single-level correction frame with 6 struts. And in this case, we correct the limb length discrepancy using the fixator. The X-ray looks a little funny, we know that, but when we take long pictures after long X-rays after the procedure, it's very well aligned. And this is something very important because we can produce minimally invasive correction in both planes with excellent results for the patient. And this will leave us in a much better state for future procedures in case we have to do something else. Just to finish the post-op protocol, we do some weight bearing inflantigrade as soon as possible. There is a very gradual correction, and the frame removal is done when the CT scan is showing bone healing, and we use afterwards a short like walking boot for 3 or 4 weeks. There's some literature that I will not start by mention it, but it's very scarce for these type of problems. And what was said before, but most surgical techniques for angular correction of periarticular deformities have focused only in the supramalleolar region. We should start to take care of the extraarticular limb deformity as it may play a major role, not only in the joint sparing procedures, and also in ankle fusion and total ankle replacement. There are some of authors that are coming to assess this. This is a very important study of our friend Scott Ellis with Austin and Rob, that they are using this combined approach of limb reconstruction and ankle replacement, and probably this will make the results much better and the longevity of the implants will be much better. So these are the take-home message, and always look up. Extraarticular limb alignment is very important, and this is a great opportunity also for ankle distraction. Thanks very much.